She's a registered nurse who works at the hospital, and she's certified in wound care. She's one of the few in the state of New Mexico that actually is. And she's done her presentations for past classes, and they're always excellent. So, all of you.
Yeah, so we have currently 5 wound care nurses at the hospital. I work, it's on the second floor, and it is with the physical therapist, occupational therapist, and speech therapist. I'm also a certified rehab nurse, so it kind of all goes together, rehab, wound care. So yeah, it's definitely interesting, and I actually get my payment out of the PT budget. So at San Juan, the PTs actually did the wound care. They became extremely busy and hired some nurses to do it. So it's kind of been like that ever since. And across the United States, you will find that the physical therapists, they do the wound care in a lot of different places. I currently have a friend that's in Tennessee, and at her hospital, the PT actually assesses the patient, decides everything to do for the wounds, and the nurses do it. So it's just kind of standard practice. So, and it makes sense if you think about it, because you know all the structures, you know where everything is inside the body, and how things would look on a wound, and so it just makes more sense. But at this hospital, we have the ability to train nurses, and so kind of frees up the PTs to go do whatever they need to do as far as getting people out of bed and moving them around. So then I do it. Like I said, we do have 5 wound care nurses at the hospital, and then we have some that are full-time and some that are part-time, and we are there from Monday to Sunday. So before we weren't there on the weekend, and now we are on the weekend, but we're out of there as soon as possible on Sunday. So people are like, I thought you were here in the emergency department. But no, we leave whenever we can. We prioritize. So just know that if you go over to the hospital as a student and you want to tour and watch kind of things that happen, they normally assign, if you want, to come and follow the wound care team around. And so it's kind of fun. You see a lot of different things, and it exposes you to it before you're out on your own. And that way you're not so nervous. After the presentation, I have some supplies out for you guys to look at. I have a wound vac, which is one of those things that most people want to see, because it can be a little intimidating, and it's good to see it beforehand, before you're kind of thrown to the wolves to work with it. It always comes with a book, so all your equipment in a hospital is going to have a book to read, and it's actually KCI for these wound vacs. It's extremely easy to understand. It's very user friendly, and you can also call the 1-800 number. So we'll walk over that after the presentation. So we're going to go over wound care and a little bit of ostomy stuff, because that's something else you're going to come across when you're trying to transfer patients and work with them. They might have an appliance on their abdomen that you're trying to manage and work with, and if it pops off, then they're kind of in a situation. It kind of helps to know a little bit more about that. You can always go and get the nurse if you need, of course, but it's helpful to have some of that information. So welcome. It is exciting that we have a wound care team, because a lot of hospitals don't. They just don't have people to do the wounds, and they do leave it to the nurses, and without training, it can be very difficult. You're not sure what you're looking at, you're not sure what you need to do. So we're going to go over some things. Skin integrity, the risk factors, and the grading scale. Those are the kind of things whenever you're researching your patient before you work with them that you need to know. Of course, the skin assessment, looking at their skin, is there something that you need to be worried about? And then letting the right person know. Caring for the skin, pressure ulcers, so there's a lot of pressure ulcers that are going on, and of course movement is extremely important for them, not to receive those pressure ulcers, but if they don't get the movement, it's just some information that we'll go over. Of course, the wounds, the wound vac, and then the ostomy. So it's extremely important to know your patient, doing a head-to-toe assessment assessment, but looking at the skin in general is important and seeing what structures you need to be aware of. And paying attention to special pressure areas like the ears, the elbows, the feet, medical devices. So right now at the hospital, there's an initiative to stop all of those types of things from happening to patients. So we're going in and checking all these things here. You've got your blood pressure cuff, you've got your whatever that goes on the finger, oxygen tubing behind the ear and on the face. So those kind of things are really important for us to be paying attention to, anybody that's caring for the patient. So things to check. So the bony prominences, of course, just making sure that that area is good. Lower extremities, just because a lot of times people neglect those, they'll neglect their legs, of course, they don't feel good, they don't want to get out of bed. Buttock, sacrum, and the coccyx, of course, because they're sitting on it. The greater trochanter, the ischial, lateralis, medialis, and the elbows. Lots of times you guys are hands-on getting to see the patient sometimes before the nurse even gets to see the patient. So you're first on looking and seeing, and it's really good for you to make sure that you're putting those things in your notes. Which I just have, because you guys do soap notes. Yeah, and nurses don't. We do like narratives, we do like long books, And so still just, and I've been working at the hospital all this time, and it's just kind of crazy that soap notes still kind of like, I just want to see it all. So making sure that that's in your note can be really helpful to the doctor along with the nurse. So the things that we're assessing for with the skin, the color, the temperature, if there's drainage, odor, of course, pressure and loose items in the bed. Just the other day I found a pressure on a person. I came in and they're in a wheelchair and they definitely have needed PT, but I was the first one on scene to see them when they got into the room. And I repositioned her, and then I found those, it's called Occutane. It's where they attach to the tubing in a PICC line to draw out blood. And it was in her bed, and I don't know how long, but she ended up having a pressure injury from it on her leg. So those types of things, I mean, people are coming in and out quickly, and they leave things behind. I call them bed buddies, because they have a lot of different bed buddies. So it's just making sure those things are out of the bed are important. So some pressure injuries that you guys could come across, you might see. So of course, I'm pretty sure every single medical facility where somebody would be staying across the United States has an initiative to stop this from happening. Definitely here at San Juan, but this is definitely something that everybody wants to stop. And it's not just because it's bad for the patient. A lot of it does come down to money. So there are a lot of things that we have to watch and manage. Because if you have a lot of these, that means you're not taking really good care of the patient. And so then insurance companies don't want to pay you. So then you run into some issues. So making sure that we document and prevent these is extremely important. So just taking care of the skin and checking it as soon as possible. A lot of actually my consults are from the therapist. They'll call me up, hey, I just transferred this person and their backside is leaking. You might want to check it out. It's blanching, but so a lot of these kind of things, because you're right there touching the patient, moving the patient. You're not just casually walking in saying hello. You're getting them moving. And of course, it's important to check it every shift. There's of course high-risk patients that come priority when it comes to this, so we have to be out there. And then the repositioning. And so you need to be ready to explain. Some of the nurses or staff that you're working with, wherever you're located, they might not really understand this. They might not understand why this bony prominence is and the weight and all of that. And so it's really important for you guys to encourage them and explain to them and educate them why it's every 2 hours. studies have been done, and they say that we move every 15 minutes, even in our sleep. So there's this constant shift because our bones pressing down on those blood vessels decrease the nutrition to that area. So it's really important that we're moving those patients as much as possible. And this is just an interesting little tidbit. The 2 hours, does anybody know where that came from? So it came from the military. During one of the times that there was a war, and there was, back in the hospital, they just had these long hallways, right? And everybody was lined up. And there was a physician that came in, and these people had, broken bones, and they were in casts, and he started noticing when he was removing the casts, these areas with pressure and wounds. So he wanted to stop that. So he's like, well, we need to get them off of it. So he told the nurse that was next to him, reposition this patient and that one, just go all the way down the hall and then come all the way back up and then come and get me. So she did that, and it took her 2 hours to reposition all those patients in that hallway. She came up to him and told him, okay, hey, I'm done. He says, that took you 2 hours. You gotta go back and do it again. It's been 2 hours. So he was worried about the night shift coming on and not understanding what to do. So when he wrote the order, it was every 2 hours, because he knew it took her 2 hours to get down and back, so it should take them 2 hours down and back. And so hence this kind of evolved and just stayed with us until currently, every 2 hours reposition. But if you've worked with patients, you know that sometimes it's 2 hours is too long. They might need every hour. They might need every 30 minutes. It depends on their skin, how fragile they are, and their movement abilities. So if you're seeing that red skin, it is important to protect it. We use a lot of barrier creams just because they're safe. A lot of people, when they come into the hospital, are sick, and so they're incontinent. So barrier creams are a little safer than putting a dressing on it. You can keep an eye on it, you can monitor it. So we have a rule of 30 that's important for you guys to know. And in most hospitals, this is the case. In a lot of nursing homes, this is the case. Just making sure that that bed is at 30. You're thinking about the body and how it's sitting and where pressures can be, so that's important to know. Most beds have a little measure on the side where you can tell where they're going. So some pressure injuries that we're going to look at here. And there's different stages. So, looking at this right here, actually, maybe I should look at my hands better. So the first one that you're seeing there, this has a little weight, doesn't it? That one. So right here is kind of a concern for me that this would open up, but right now this is a stage 1. So it's just skin that's pink and not blanching, so blood flow's not getting to it. And like I said, a lot of the PTs will call me when this is happening right here. The second item that you're seeing there, that's going to be a stage 2. Actually, it can be unstageable, just for the simple fact that this coloration that's right in here, I'm unable to see the structures, but this is a blister. And blisters are stage 2s. This is kind of mixed etiology. And then behind the ear, right here, so it's open skin. This can easily become unstageable because there's not much there, right? We don't have much flesh there. It goes straight to the cartilage. And then, of course, right here we have this open skin, but it's past that superficial state, so this would be a stage 3. And then that would be an unstageable. So we can't see the structures, right? So we know most likely that we're going to see a bone in there, right? Or it's going to be really palpable. We'll be able to feel that bone definitely within that structure.
So, Nikki, can you clarify what is unstageable and when an unstageable becomes stageable?
Yes. So unstageable means that, one, you can't see or identify the structures that are there. Okay, so if you have slough or that necrotic tissue, it's in the way for you to see exactly how deep the wound is, okay? So then that's why we're saying that it's unstageable. You could also have eschar, so that's a very thick, dehydrated necrosis, a scab. It's not a scab, I'm just trying to get your minds into that area. So it's like leather, it's normally very dark in color, black, sometimes a really dark brown, and it feels like leather when you touch it. That too is gonna be unstageable because we don't know what's underneath it. It's the body's natural way of sealing itself off to heal underneath, but that's gonna be unstageable too. It becomes stageable when you can identify the structures that are underneath, be it the dermis, a muscle, a bone, or it's extremely superficial and it's just the top layer of skin. So whenever you look at it and it's clean cut and you're like, yes, that's what this is, then that's when you're staging it as a 1, 2, 3, or 4. It's unstageable if you cannot identify the structures.
Now, do you consider a blister unstageable or is it stageable?
It is, it's a stage 2.
Okay.
So the one that was on there, how do I go back? Is it this way back? There we go. Sorry, I don't normally use this, I normally use the little. So this one right here. So this blister in itself, I would want to say that that was a stage 2, because I know that that top layer of skin now is filled with the fluid, so underneath that's exposed tissue. Okay, so it's a stage 2. But having this necrotic look over here, I can't see clearly to the bottom. So on this blister, most blisters, it's clear or light yellow, and you can actually see right through it to the tissue underneath. So that's why I'm confident saying that's a stage 2. But this other part, I don't know, because I can't see clearly what's underneath it. So I would say, like I said, mixed etiology on this, but a doctor is going to pick the unstageable point. And with blisters, we don't know sometimes really how far they go when you've got this combination. So I would say mixed etiology, but it could change. And I do have some more photos of these, but like I said, this one would be a stage 3 because it's obvious if you look at the depth of that. Can you guys see it okay? Or should we turn the lights off? There we go. Does that help?
Yeah.
So this right here has no necrotic tissue in it. So I'm not going to say it's unstageable because I can actually see my tissue here. And then and you look at that edge and you can tell that it goes a little deeper than just superficial. Yes?
So what action are you taking when it's unstageable? You're documenting it and someone else is
So-
going to debride or
At
assess?
this hospital, I'm allowed to debride because I've been signed off on that and monitored for 4 years, so they're okay with me debriding. But on something like this right here, the surgeon's gonna be called to come in. Now, depending on the state of this person, let's say that they are not surgically able, like they can't come in and work with this person for whatever reason, they're unstable for surgical procedures. We do have the ability with the wound vac to do what we call instill. And we'll go over that, but just since we're talking about the unstables, I can hook a bag of solution to this and I can flush that wound out and clean out that necrotic tissue without surgery and without a sharp object. It does take a while, but it's safer for this person. So there are other treatments than just surgical intervention for unstageables. This particular one, most likely I'm thinking, the surgeon will go in and clean that out. It's gonna be to the bone. I'm gonna be having to protect the bone, and then I'm gonna be putting foam in that. Some of these patients are coming from nursing homes and nobody's been looking at their backside for a while. So if it's that case and they're very fragile, then I would be using the instill. They would debride what they could superficially. A lot of the nerve endings have already been disrupted in this patient, so they're not gonna feel as much as this person, right? Because these nerve endings, it's kind of like a burn when you get a burn, right? You have stages of burns. because of the tissue and how it feels. So the deeper the burn, the less sensation, because you've killed off those nerve endings, deadened them, and the more superficial the burn, the more pain within. So in actuality, we might see somebody with this and this telling me, ow, 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 ow. And this person might, they're not feeling it. They might feel these edges that look very indurated. This definitely looks like there is pain with it. I'm not saying there's no pain, but definitely a surgeon I would be calling for this one. For this one, if the person's incontinent, I can put a dressing on it, but as you see, there's barrier cream. So that's and see, it looks like it's starting to happen right there too. So they're definitely having moisture-associated breakdown from incontinency, which weakens the skin, and tons of studies have been done on that. It definitely causes more pressure. It makes your job harder too, because you're going in there to take care of the patient, to get them up and move them around and give them some exercising. You got to clean up and all of those kind of things. So you guys might run into this a lot more. Did I answer your question, or are you okay?
Mhm.
So everyone's at risk. Right now we're doing the Braden assessments, which are things that nurses ask the patient and the family when they're admitted, and they figure out on a scale of where they fall is a risk factor through the Braden scale. And so if they're mobile or immobile, do they need assistance? They don't, incontinent, this and that, back and forth. There's a whole list of questions that they go through. And at the end, they're given a score. So right now, currently at the hospital, what we're doing is 18 and under, I get consulted. And those patients likewise are being seen by the PTs, the OTs, and some are seeing speech, but definitely the PTs and the PTAs. So we're trying to just stop those pressures and intervene as soon as possible. But I'm finding pressure injuries on people that are scoring an 18, which is pretty good score. I mean, it's not that bad. So you can have 25 to 18, and most of us right here, we're 25 and we're doing great, right? But once you get into the hospital, you're not doing so good, and so your score comes down a little. And I'm finding pressure injuries on people that are just getting admitted, and they're walking and talking and doing stuff. So you can anyone can get one. It's not just somebody that's laying in bed all day. Anyone can get one. Okay, so right here we have another mixed etiology. You see these little purple areas? Those are deep tissue. And then of course this looks superficial. You can see how the skin's rolling away, so I want to say that this is a stage 2. But it's mixed. This is the S scar I was talking about. So that's going to be unstageable. Unstageable, because I can't see because of the structures here. Unstageable. Can't see the structures. Yes?
How do you handle the SR? Is it any different?
No, actually, I want to slap surgeons, sorry. They want to remove that, and I don't want that removed. I want it to stay in place. The body's trying to protect itself, and if for something to get this bad, something's really going on with that patient. Surgeons don't like S-scar, they want to remove it. And so, for me, I just want to protect it. So I want to make sure this person is moved every hour. I want to make sure that they're putting barrier cream on it because it has zinc, it has some great properties to it to help the skin. So there's some things that we could do besides cutting that open. But yeah, definitely I would want to leave that one alone. This one right here might be a candidate for maggots if I know that the depth of the tissue death doesn't go too far. I might want to put maggots in that, clean that up. I could do meta honey. There's a lot, just depending on the patient and what they're comfortable with. This one right here definitely needs some debridement if this person can tolerate that. And then using something within the wound to keep it moist. So possibly meta honey or a wound vac. And then, I don't know why this came up all separate. So the heels, like I said, you guys are going to be seeing a lot of fragile. And then this right here is a DTI. So this looks like a blister, but it's got that purple nature to it, so I'm gonna call that a DTI. DTI, deep tissue injury, also create blisters. So we really don't know how deep because of the purple in color. I can't really say it's a stage 2 because I can't see the bottom of that blister. So having the incontinence, like I said earlier, can lead to having the pressure injuries. It's really good to have them on a toileting schedule. So, like I said, I'm a rehab nurse, so my brain thinks rehab. A lot of the nurses that you will work with on the floor and within nursing homes or within, or even family members within homes, going to see patients out in their homes. They don't get this, so this is really an important thing. When somebody is not feeling good, to have them on a schedule. It just helps you, it helps them, especially if they have issues with being paralyzed or they're not able to move. Just having that schedule helps the body completely. Toileting is extremely. I had an eye-opener. Here I was at the rehab here, and I learned my FIMS, and I learned all about scoring patients on how they move and throughout the day and whatnot. Then I got to the hospital, I was like, I said, nobody's on a schedule. Everybody uses this schedule. And not using that Foley catheter if you don't have to, and making sure, for some people it is a necessity and you have no choice, but those that you can actually work with and give them that ability to have more freedom, even straight caffeine, is better than having the Foley in place the whole time. Of course, they don't like me because I'm always like, no depends. I don't want this patient to have depends. Let's use the blue pads, because then it's open to air, and you know when they've gone, and nothing is staying close to the skin. So, of course, yeast infections and skin issues because of urine, all these things can really hurt the tissue. So we're going to go into necrotizing fasciitis. So that is something that is in this area. It's all over the United States, but we have a high prevalence of it. And because of this, a lot of those structures that are affected are going to need mobility. You're going to need a lot of therapy. So this person particularly, as you can tell, so in the process of healing this wound, we also don't want to lose the ability for this leg to flex and to be usable. This stuff moves so fast. It's not something that's like, it took a week. That's not neck fash. Neck fash is fast. Within 30 minutes to an hour, you're seeing changes. Every 30 minutes, you're seeing something move up the leg. The majority of the people in this area will say that they felt a little sting or something, kind of felt like something bit them. It's kind of the same thing over and over again, and it's normally on an extremity of some nature. It feels like a little sting, and next thing you know, it's super red. And within an hour, it's moved up their legs. They need to get into the hospital. It just travels along the fascia, and it goes. And it destroys everything that it can in its way. And you can die from this, and I've seen that. If they don't get in there quick enough and cut above the neck fash, the person will expire. So, once again, sorry, I don't know why my pictures are like backwards. That one's supposed to come first. So this is what the person had going on, and then they have to get in and cut it out. So it just looks like this redness, signs and symptoms are everything that you would think of something that's infected, right? So you've got a fever, you've got warmth, some induration, and then maybe an odor or something draining. So they get in there and then they're going to have to remove everything. This is another thing that we have a lot of in this area. And you'll be working with patients with both the acute or in the home setting. So the neck fash after they're recovering, the calciphylactics kind of stuff is something that you could encounter in any environment. So for whatever reason, there's a lot of reasons why the person would have this. In this area, we see it because they are renal patients and they are getting dialyzed. And so they have a buildup, and calcium will destroy. It just builds up within the blood vessels. It destroys that whole area. It's extremely painful. They won't want to move for you. They don't want you to touch the area. And the best thing to do for a renal patient is to keep it dry. So if you are out and about in the world and you come across a renal patient with calcium, do not debride. Do your best to be that patient's advocate. Keep it dry. Keep it dry. Because everything is dead underneath it. You're going to open it up and spread it even more. And then now they're going to get an infection because they have no way to heal that. So having that eschar-like tissue on the top of it is the only way to keep it safe. Now, if not, if they don't have that, there are people that get this and they are not renal patients, and they get stuff more like this, and you can actually see this white calcium buildup. So a lot of these patients that don't have renal issues, they are surgical candidates, and they can go in there and they can debride. Now, if they don't figure out why they're doing that, you're gonna keep running into problems. So it's really cool to get in there and figure out why are they building up this calcium. You know, this is also probably somebody that gets kidney stones, and I don't know, maybe they drink soda 24/7 their whole entire life from the time they were a baby. But you know, something's causing this. And if they get in there and cut that out, then the tissue can heal. But definitely not in someone like this or like this, okay? And this is just different stages of how it starts. Very painful, very, very painful. So they won't want to move their arm. For some reason, it likes soft tissue on renal patients, so they'll get it on their abdomen, they'll get it on their breast, they'll get it sometimes in their groin. Men will get it on their penis. It's extremely, extremely painful. We do have protocol for it when it happens. Medically, there's some things that they can do within their blood system to help. It just takes a really long time. And there's one in the penis. But yeah, this is a great area for studying this because we have a lot. Okay, wounds, wounds, and wounds, and more wounds. So let's see here. This one right here was an IV infiltration. So, you know, they'll get their IVs, and if you notice that one's leaking, it's so important to tell the nurse. They need to stop that right away. Because what's happening is that fluid, whatever it is, whatever medication it is, it's now going into the tissue, right? And it can get down into the muscle, and then it can just kill everything. So it's really important to get that stopped. I wasn't there for this one, but if I remember correctly, this woman was kicked by a horse. And it just destroyed tons of tissue within her. Here we've got a lot of burns going on. You know, there's just a lot of these things that can happen to people. The body, as you can see right here, wants to form an eschar. Can you see how that's wanting to darken up? So the body wants to protect itself. It's just our natural way. Some road rash, motorcycle accident. And back in the day, they would put them in the whirlpool and they wanted to breed them. So we don't do that anymore because it's not effective. You know, you're sitting there with all that bacteria. So we don't do that anymore. But it is good to get these people in the showers to wash off some of this stuff. It's amazing what soap and water can do. Some of the products that we use, and I have them here on the table for you guys to check out. We've got some common dressings. You might see Zero Form if they're after surgery. That's this right here. So it has a yellow color to it, and it has a film on it, and it will kill bacteria, and a surgeon will put it down over whatever he's worked on. So if you see that, and you're working with someone that's a surgical dressing normally, and so you'd want to see if there were orders to change that dressing or not, or if the surgeon hasn't seen it. Everyone gets busy, sometimes people get forgotten, so you know, letting the surgeon know, hey, I think you forgot something, they probably would appreciate it. We don't use the knee salt, we do use Safe Skin. Beautiful stuff to use, to help patients cover their skin in areas that need more protection. ABD pads, adaptive, you'll see some of these things on patients whenever they have a surgical dressing. Let's say they had staples placed or sutures, you'll see some of this adaptive and covered with an ABD pad, pretty simple dressing. We also have Methylex borders. These can be bought, the ABD pads, I know they have them at Walmart, so they have adaptive. These items too. So patients can get these, they can't get the opsite, but they can get these other things. Another thing, when you're a wound care nurse, you need to be creative. They like to call it MacGyvering. So they call me MacGyver a lot. I'm always trying to think of cool ways to keep dressing intact for the patient for at least 2 days if I can, because then that's less pain and less issues. Recently, we had a woman that had diabetes, and she had 2 wounds, or 2 abscesses in her buttocks, right next to her anus. But we tried to put a wound back, but it was kind of shaped like a butterfly, and you don't want to just cover the anus, you've got to go to the bathroom. So we ended up getting pretty creative, and we used some Duoderm after we put the dressing in to cover it, but then she didn't like the thickness of it, so we did an opsite. So it's just being creative. It's really good. If you did good in kindergarten, you can do good in wound care. Gotta be able to cut and paste well. More products that we use. Skin Prep. Love this stuff. It's amazing. I would like to buy stock in it. It comes in different forms. It comes in different, like this is in a pad form. It comes in lollipops. It protects the skin. So as long as the skin is clean, so I recommend cleaning it up with chlorhexidine or something of that nature. If they have some scabs, you can put the Skin Prep over those scabs. And so when you're working with them in transfers, rubbing up against them or whatever, these scabs aren't going to come off on you. So it's good to keep things sealed. A lot of the therapists say they are super happy that I have that order in place because they get the heebie-jeebies sometimes. There's a lot of different creams that you can use. We do have Santyl at the hospital. It's a very slow debridement cream that you can use. We don't use this enzyme. We use maggots more. We do have, I don't know if any of you know or ever heard the name Dr. What's his name? Hoffman? Dr. Hoffman? Do you remember Dr. Hoffman at the hospital?
Yeah.
So he was the one that really helped us get maggots. So we have medical grade maggots, and we use them to clean out wounds. They work way faster than this, super fast, and they only eat dead tissue. So we get them out of California. It's kind of fun. We don't do leeches because we don't do a lot of repair of those appendages that fall off. We don't do that. We send them away. It's hard to keep a leech on anyway. You're all day long trying to keep the leech on to bring blood flow to the organs. So yeah, we don't do that. I don't use this as much, the Silver Sorb gel, but I do use Silver Cell sheets. That calcifolactic, that's great to put on there. Silver is a wonderful product. It kills bacteria. Really good thing to use. So just some of these things that you might see too in their home is Safe Gel, Solosite. These are the Sensicare, the Aloe Vista, which I like, and this is another form of skin prep. So we don't do a lot of Prevalon boots, but you will see them pretty expensive. I like pillows way better because you can visualize that foot, making sure the heel is floating. To me, it's just a little more effective. And then you also don't have to worry about this crease in here causing a pressure injury. So I just like to float the heels with pillows. It works so much better. So just some of the things that we use, wound packing. And every facility is going to be different. And if you're doing home health and that type of thing, they're going to have their own list of supplies that you The patient might have stuff at home that you're gonna be able to use. In a hospital setting, you're gonna have to follow by the guidelines of whatever it is that they purchase. But just know there's a bountiful amount of supplies out there. It's another good thing to have stock in, because everybody uses it. Burns and skin tears is one of those things too that we see a lot of, and it's a pretty simple thing. You just want to cover it with something that's not going to stick to it, and then something to pick up the drainage. So that's probably the easiest one. So the covers and the wraps you're going to see more often. So if you're not doing the wound care, somebody else has put them in there. So you're going to be seeing those covers, the Duoderm, gauzes, wraps, Perlexes. I like to use Surginet, so that's really easy to move around and manipulate with. Okay. And then different things like the Silvadene. It's a really good product for burns and for open wounds. The only thing with Silvadene is it has to be cleaned off every 12 hours. So if it's not, then the bacteria is going to grow. So it's really important to clean it off every 12 hours. The Dakins, we still do use some of that solution, which has bleach in it. We still do use that at the hospital. It's a prescription that's done by the physician. But it's really important not to use it more than 7 days. I like 3 days is my max. But for some of those neck fash people, they come in, I've seen this, it's on the foot, the dorsal of the foot. They've got a wound, it starts to spread, they cut, and they're going in every day cutting and cutting and cutting and cutting and cutting, and now they got AKA. So, that can happen really quick in 3 days. It's all gone. And that Dakin Solutions really can get in there and kill neck fash. They were doing actually a study in Shiprock because of the prevalence of diabetes along with the nephrology end of it. And these people will get neck fash a lot, and they find that it comes in bouts during certain times of the year. And it's really because they're all in one area, spending time. Families will kind of come in together and spend time together and get really, really close. And then they're transferring a lot of those natural bacteria that we have on our skin, right? Staph and strep, we carry these bacteria on us. But in somebody that already has a compromising disease process like diabetes, it can be deadly. So they can just get a little scratch, and that little scratch turns into something huge like neck fash. So, I'm still waiting for some of the research to come out, but they did a study for several years there in Shiprock, kind of monitoring. So the incontinencies, the Alavista, there's an antifungal, we've got Sincicare, we've got skin prep, those kind of things when people are having incontinencies. Pressure relief, so we do have the Prevalon boots and pillows, like I said, I think those are extremely important. Dry skin and skin treatments, we do have a bunch of different things that you can put on this skin to keep it moist and supple so it's more pliable. So some surgical wounds that you guys can encounter depending on where you're working. Like I had said earlier, if you come across a surgical dressing, you'll definitely know. They're not dated. But you'll see some of the standard things, and you'll ask the nurse, and she'll say, no, that's a surgical dressing, so we don't mess with it. So it's very important to talk to the surgeon before you remove it. They all have their reasons. We had an incident one time where this dressing had been on for a while, and the podiatrist had not come to remove it. And one of the wound care ladies did go in and remove it, and it smelled so bad. It was just this horrible odor. Well, it was a graft, and there's something called apple grafts that they use on diabetics on their feet, and they smell horrendous, but they're fine. There's nothing wrong with them. They're supposed to smell. That's the way it is. And a lot of those grafts, if it doesn't come from the patient, right, they can't, you can imagine if somebody is diabetic and renal, they're not gonna be able to graft from them, right? Cause then now they've got 2 wounds that they're feeling, so they have to get a graft site from another source. And the main source for those apple grafts are, and they're donated, I don't know how, but it's whenever, little boys are circumcised, they save that tissue, and they use that tissue in grafts. And, like I said, I don't know the whole process of it, or if it's a donation process or whatever, but it is used that way, and they stink. Really, really bad. So if you're smelling this odor and it's a surgical incision, kind of do a little research to see if they used a graft in it. So normally within the first 24 hours they change the dressing and then they write orders. They're supposed to write orders, but they don't sometimes. So it's just following up and making sure. I don't like to reinforce for drainage. It's on there because it's kind of a standard practice that people do, but I think if it has that much drainage, you better take it off. There's something going on underneath. You gotta make sure that skin is intact and safe, because it can cause a total havoc on that person. So if it hasn't been changed, and you're the first one on scene to be looking at that person, and you notice it's been 24 hours, have the nurse or you yourself, if you're confident and comfortable, call the doctor and see what they want to have. Actually, the PTAs and the PTs at our hospital both have a really good rapport with the doctors. They're talking to them on a constant basis, just as much as the nurses are. So types of interventions to be used for the wounds. So we've got wound vac therapy, which I'm going to turn on here in a minute. I'll let you guys see how that looks. Debridement, we've got sharp. We also have ultrasonic at the hospital. We'll use a normal saline along with a sonic pressure, and we'll clean out wounds. That's kind of fun, cleaning out the wound that way. It's just extremely messy, so you got to be covered. So if you guys are doing rotations over there, you can see. I just tell the students, just come up to the wound care team and ask them what you're doing this week. When would be the best time for me to come and see some cool stuff. And so we do this on I'd say probably every other week or so. It's not appropriate for everybody, but for a lot of wounds it is. Ointments, jellies, creams, those kind of things, of course, you can use to help with wound treatments. There are specific dressings that you can use for certain wounds, and most of your facilities are going to have a book, some sort of resource book for you to go to and look at, or you can always call somebody. Maybe you guys stay in contact. I have other wound care nurses that will call me. We've gone to classes together, and they'll shoot me a text message, hey, I've got this patient, blah, 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 what should I do? So I encourage you guys to reach out to each other, because you're going to come across stuff that maybe somebody else hasn't seen, and then you can help somebody else. So communication with wound care is extremely important, because there might be a product out there that's really helping. Like for example, outpatient was using collagen in wounds, which I love collagen. It's pure protein, just slap it down in there. Especially if I have a structure, a tendon, or a muscle that's exposed, I'm gonna put collagen on it, and it helps it. It's a matrix, it helps things grow faster. So outpatient was using it, but we didn't have it in the hospital. Once again, communication, So it's just really important for everyone to stay in contact and share the information that you get. So I'm going to be showing you some pictures, but I also brought it. So this is the wound vac that I brought today. The ones that we have at the hospital has this cute little door here. There's a little pin that you can use. Most people don't know about it, but you can use this. So if you're wearing your gloves and it's not paying attention to your finger, use this. They also have a bunch of different settings. So before, we used different devices. There were Aptheras. So patients that are in ICU, if a surgeon has worked on them, they're going to have an Apthera, and you will not be working with them. If they have an Apthera, maybe you're going to be doing some hand and leg things, but they're not getting out of bed. Their abdomen is open. Fascia, everything is open. So there is a foam that's on top of it holding their intestines in. So you won't be getting them out of bed, but they might have you do some simple mobilities in bed. Your standard wound vac is gonna have this black foam in it. And there's a bunch of different things that we can put to protect the structures underneath. And I have them up here. So of course it's the latest technology. Before we used to do the moist to dry dressings, and depending on the wound and the size of the wound, twice a day, 3 times a day, 4 times a day, depending. And every time you remove the gauze, the moist gauze that now has dried inside the tissue, it's non-selective in debriding. It takes good and bad, okay? The wound vac does too, it takes good and bad, but it's in a shorter amount of time. So let's say an abdominal wound would have taken 6 to 9 months to heal, I can now get it heal in a month and a half to 2, okay? So it's just a shorter amount of time that we're messing with that tissue. Also reducing edema, because we're in the process of sucking it out, right? So most of your wound vacs are set at 125. It also carries away the drainage, it keeps it off of the tissue, where your gauze dressing does not keep it off of the tissue, it sits there, okay? So whatever bacteria is still sitting there. It increases the blood flow, which you need to be careful then if your patient has vascular issues, depending on what type, the pressure could be adjusted depending on if they have vascular wounds that you're treating. You don't want to have too much of a tension because they need a less pressure. So just do your research on what type of wound they have. Causes granulation, we're kind of pulling up the tissue bed, right? We're pulling at it, we're making it want to grow, because then you can graft it if you need to, or it can close. So not only with a wound, whenever you put a wound vac on it, are you worried about the inside growing up, you also need to worry about the sides coming in. And there's a drape that you put around the tissue, the peri-wound, the skin, to keep it protected. If you bring that in just a little, it can help that skin continue to grow over. If you don't, the foam is going to stop it from coming over. So just note to self, if you have to change a wound vac dressing, it's good to have a little over on the edge. Reduces pain and infection. I've seen that. A lot of people will disagree because they say it's painful to remove, but if I was removing that 4 times a day, kind of, it is less pain actually. And there is a way to decrease the pain. You can soak the wound. So this is sitting on top of it, and you can cut this and fill it up through the hose. You can put normal saline inside that foam and let it sit there, and it will loosen up off the tissue. So when you go to remove it, it's not as painful. You can also put, to protect the structures, you can put a Mepitel over it, which is like a silicone sheet that has holes all in it, but it doesn't stick, and so it decreases pain by using that. So there are some things that you can use to decrease the pain. It also increases oxygen to the wound because it's increasing the blood flow, which carries oxygen. And so then that blood also can take away toxins, so they just help each other out. A wound vac, this is an old track pad, we don't use those kind anymore. But this is what you would see, something like that. So we check it, there, like I said, I was talking to you about the pressures. You can go up to 150 if it's a really big wound. I've had it to where I've got several wounds. I've got one on the buttock, one on the back, one on the abdomen. They were in a major car accident and they've got these issues, or a gunshot wound, and you've got different areas. So I'm going to have to increase the pressure because I've got a lot of sites that I'm pulling at instead of just one. Checking the drainage. What color is it? Kind of the standard thing for that. This has a canister on it that slides in right here, making sure that that's in place, and that's something that's important too, because a lot of therapists will get the patient up and they'll be going down the hall and that will pop off. So knowing how to put that in place is important. Checking that the dressing's intact. Listening for leaks, I do it like a tire. So that skin prep stuff I talked about, I'll put that all over this dressing and then listen. And you can hear it bubbling. And let's say the leak was here, it'll suck it up, and then you'll see a moist spot right here. So, like I said, you gotta MacGyver things and kind of figure out how to fix this leak. But you can just use a skin prep, because the thing is, you don't wanna take this off if you don't have to, right? We want it to stay. We change them Monday, Wednesdays, and Fridays. Dressings can go 72 hours without being changed. We do our best to every other day. If it's been 2 hours and you've got a leak and so it doesn't have a good suction, it's gotta be removed. So if you're the one having to remove it because it's at the 2-hour mark, there's products hopefully in the room to help you, or at their house or wherever they are coming to see you. There's sprays that we send home with the patients to help remove these little sprays here. It removes adhesive, and I like to leave them in the room for the patient because it also removes any adhesive. I mean, any tape that they have on their IV sites, anything from the oxygen tubing if it was taped down for like a little kid or something. So this stuff is really good. And then there's different types of foam. So the silver foam, which I'm gonna pass this around for you guys to start looking at, because I really want everyone to see this. This is the Instill. This was, and I've got photos in here. They're a bit graphic, so hopefully you guys will be okay with that. I'll just pass that around for you to look at. The Instill is this silver foam, and it flushes out. Like I said, you put a bag here, and it attaches to. It's got these two pieces, one for suction, one for fluid. Okay, so I'll pass that around too for you guys to take a look at. The pictures that you're gonna see here, I have a date at the bottom. I was super excited because most of the doctors, everybody's leery of trying anything new, right? They're like, But there was a guy that came in, this happens all the time, I don't know why, for men and women, they're doing something with the cooler on top of the roof and they don't have a ladder, and then they gotta get down. Well, he jumped, and he broke both heels. Both of them. And he broke something else, I don't remember what else it was, but he broke something else, and then he went into the doctor, and he wasn't feeling so good, of course, and then, he noticed something red on him. A healthy guy, nothing wrong with him. I think he might have been anywhere from 28 to 32, somewhere in there. He noticed a red mark on his leg after this break. So when they checked him, they're like, that's interesting. It was neck fash. So not sure how he, from down there to here, but they had to surgically debride his groin. Because they have to go outside of that area. So that's what these are pictures of. And I was able to, the doctor let me put Instill. So Instill is a foam that has holes in it, and when you place it down, it aids in granulation. It wants to pull the tissue up through the foam. And of course, debridement and all that good stuff. But they wanted to graft him and get him moving as soon as possible. So this kind of aided it in that structure growing faster, so then they could put a graft on. The graft ended up failing, and they ended up just having to take it all off. But at least I got to try Instill. And so since then, we've been able to really use it a lot. Doctors are saying that it's a really productive product. These wound vacs, supposedly, KCI said they're going to get rid of the black foam, and they're going to get rid of the white foam, and they're going to mainly use this gray foam. There's also the silver foam. There's you can only use that though for 7 days. You got to take a break because it will turn the tissue gray. And then white foam, which none of us like to use. It's very dense, and it really does not. It keeps a tunnel open. So you're trying to keep a tunnel open because you don't want the top to close and leave this hole for an abscess. So there's a white foam that you can pack in there. Well, you can use that gray foam now. So we're trying to get away from this white foam because it's not that safe. So the wound vac is normally applied by a wound care team member, a surgeon, or a PT. So where I'm working, I before we got there, so they all have stories, but Todd Thompson is one of my managers, and he's placed multiple wound vacs and done tons of wound care treatment. He was actually involved in helping train and whatnot a bunch of the nurses when we first started out. Diane McCall, Ann Price, they're all managers now, but they're all physical therapists, and that's what they do. Tons of this stuff. I've actually had to call them and have them help me, because I have to go down to the OR and in the middle of a wound vac change, and I need help. And so they've come and done those things. So you might get the situation where you're having to do it. Always in a clean wound, if it's 20% necrotic, we recommend you don't put the wound back. Instead, try to get that necrotic tissue out, because it's not going to grow. It's not going to granulate. Lots of times there's a lot of bleeding. That collagen that I mentioned, it actually stabilizes blood loss, so you can actually use a collagen to decrease blood loss and then put your wound back. So HD, so a hemodialysis access spot, so they removed it. As you see the wounds, 2 weeks of therapy, so see the new granulation. So the closer, and see there's a little blister here. Now I wouldn't call that a DTI, because see how it's really dark, I can't see the base. But most likely it was from the drape. Can you see the wrinkles from the drape? A lot of times people will have reactions to the drape, and so they'll get blisters. And depending on the person, maybe that's what happened here, but it looks like a DTI to me, so I don't know where they have the pad. It could have been in that area. So, a motor vehicle accident. And it just granulates, it helps close. That's what it does, quickly. So this is just 1 week, and we've already got good tissue, enough to really work with it and try to, and like I said, you put this drape, you can kind of see this outline of where this drape has been to the skin. Because you stabilize that skin, it really does change it. It creates a moisture line too sometimes. So sometimes this will be really, really moist, and you've got to put something under it to decrease that moisture. I just bring it over, sometimes 0.1 centimeters, just enough over to continue the skin growth coming over as it's granulating from the bottom. So this is on a foot, you can definitely see structures. By looking at this, I'm just thinking this probably is not a good candidate. Here it tells you the dog licked it. So, stepped on a rock did that. It's because a dog is licking it, probably. I see that a lot. I let them lick my wounds. Oh, you guys are crazy. Did your cat lick your wounds? Yeah, it's not uncommon for us to pull very strange things out from between the toes. You know that they're living in a very dirty home. And you guys might see that if you're going out to patients' houses, you're gonna encounter some things that are really not clean and stable for a wound. So here's that foot after a month. Now, we don't have as much because there was a lot of structures there, right? There was a lot of necrotic tissue. It needed to grow a lot, and this person probably has diabetes, I would think, because you step on a rock and it gets that bad. There's some other stuff going on with it. Or a vascular, maybe they had a vascular. And then the foot, the top of the foot, see where it's granulating. You can still see those tendons. And never put foam on a tendon. Never. You gotta cover that. You gotta cover that structure. Keep it moist and cover it. So the ultrasonic debridement machine that we have a hoof head, and then we have like a ball. So that can go up into tunnels, and it shoots out with water, like I was saying, it's under it. It's a bubble head. Some tools, they're kind of fun, like I said. They can hurt because you're sending this shock to with the water to the tissue. And it's superficial, so there's gonna be more sensitivity. But it can really clean great. The nice thing is that it hydrates whatever it's touching, and it kind of explodes. And they find that long term, so you do that treatment, and you wait a couple days and you do another treatment, and it has actually hydrated a bunch of that tissue. And it's really super helpful for the healing process. Oh, that's talking to us. So here was a IV infiltration, and then after it was clean. So it just has so much more moisture to it. And moisture is the key. They used to say keep things dry. Now I know I said calciphylactic, keep dry, that's different. Escarb, that's different. But your standard wound, moisture. So, I mean, just think about it. You want these, you want to grow this muscle, you want to keep everything intact and things to move. So if you're walking across the desert, it's exhausting and you move slow. But if you pour some water, you can glide across in a boat and get to the other side. It's the same thing for your tissue. So your cells want to move, they want to do their job. Yes?
Is that done submerged?
No. No, we just hands out. We have chucks down. We wear gowns, and we have a special shield that we wear over. It looks like, you know, has and all. Freaking patients out. I'm like, what are you doing? I like to go like this with my big gloves. Nothing. It's gonna be fun. And yeah, we just out in the open. We just use the tools out in the open, and stuff splatters and showers everywhere, so you have to be covered. But yeah, now the submerging they used to do, the whirlpool, but we don't do that anymore. Now we have several of those, and I'd love to get rid of them. So I want that room that is full of these whirlpools that we don't use. If you know somebody that's interested in them. Maggots, they're cute little critters. Now I don't like it when they turn into flies. That's different. That's like your teenager. But so these little suckers, they get in there and they eat, and it doesn't hurt. And then when they eat, then they poop, and it has a chemical in it, and it helps break things down. It's black, so some people are like, "Oh my gosh, this looks horrible." It's actually good, and it's okay. Now a lot of patients, just like last week, a patient came in with maggots. It happens. This is kind of the season that a lot of flies are growing, right? We've got a lot of moisture, we're out of winter, people opening their windows, they got a wound, they're not paying attention, a fly lands in it, next thing you know they got maggots. So, those are homegrown. So we have medical grade ones. And somebody, one of the instructors for the nurses was saying, oh, we should have had like a battle, you know? Homegrown versus medical, see who won. Like the homegrown ones would have won. They got street smarts. But medical ones would be like, oh, I don't know if I should have had. So when they start out, they're this little tiny itty bitty thing, as you see here. You know, they're anywhere from 0.3 to 0.4 centimeters, itty bitty. They come in a little gauze-like container for them, and we gotta keep them moist. They're alive animals. They need to breathe. So your dressing needs to be breathable. We've placed maggots and have gone back to check on them, and somebody has covered it with an ACE wrap because it had maggots in it. Well, you just killed all the maggots. They gotta breathe. So it's cheaper than surgery. It's cheaper than surgical debridement. It's around $500 to $1,000, somewhere in there, for one batch of them to be put into a wound. And we do the measurements for it's a place out of California, a medical place out of California that grows it for us. We tell them the size of the wound, and they know how many maggots to send. And then we just use what they send. There's a whole process of how we put them in, and the tape, the glue, and all these things that we do for it. The patients say sometimes they hear them. Sometimes they can feel them, but other times they can't. It just depends. Everyone's a little different. Some people are cool with it, and those that are cool with it, it's awesome. It cleans that wound so well, you don't have to worry about any debridement at all. Other people can't handle it, so we don't offer it to everyone. You gotta kind of feel the patient out if they're gonna be cool with it. Once they're eating, they get huge, and my job then is I'm an executor, and I gotta kill them all. So I drowned most of them in normal saline and hydrogen peroxide. They can't get air when you're pouring that over the wound. You gotta be careful. Hydrogen peroxide will kill tissue fast, and you've just grown it, so you gotta be really careful. It has to be a mixture. But my goal is to get those suckers out of there, because they will crawl in deep, because they're looking for dead tissue. They don't eat anything that's healthy. They will leave it alone. Only dead tissue. So it's like nature's natural cleaner upper. So this is gonna shock some of you. So that is a man. So we get a lot of foreigners gangrene. We get neck fash down there. There's a bunch of different places that we can get this. But it cleaned it up really nice. Those maggots did. Now, getting the dressing to where they stay in place and they don't take off, that's the trick. Because, you've got creases and folds on people. But you've really got to try to contain them. We have to dispose of every single one of them. They have this person's DNA. So, we don't want them flying around giving somebody whatever they just did. So we got to get rid of all. This was a man that had cancer. And so what you're seeing is the side of his face. So we're covering up. So here's his hair, and then this is his ear. It was all had to be removed. And then he had this, and he couldn't handle ultrasonic debridement. His hearing, believe it or not, was still functional. But we couldn't do ultrasonic debridement. We couldn't put a wound back on that. What are you going to do? So our options were limited. So we had to place maggots, which scared us because, there's a bunch of structures in here. Think about the side of your face and imagine your ear gone. Where are those structures? Mouth, the neck, where are they going to go? And knowing that he had cancer. But it was our only option. We needed to try to get this tissue out so he could try to heal. And then also he was way older too. I want to say 70, 80, somewhere in there. So this was the type of dressing that they used. We make sure that we tell people there's maggots. See how it's open to air? We've got to leave air there for them to breathe. 24 hours after the therapy.
Wow.
So it took it all. But as you see, those little critters are still running around. And they have to try to get them. And they came down here into a suture line because see, there's necrotic tissue. Oh, so we had to chase them. We're chasing them. They just got down all in there. So we just continued to use the therapy. You can just see the differences of how it cleans everything up. Okay, questions? I like to. So some of the stuff that we went over, burns, there's venous, arterial, depending on their blood vessel issues. They're gonna have cardiac issues along with all of that stuff too, so then you're gonna be monitoring, moving them and their heart rate, blood pressure and all of that too. They can have a lot of mixed etiology types, lacerations, skin tears, surgical and pressure injuries. Ostomies, real quick, like I said, you could be transferring somebody and you need to worry about the appliance that they have on their abdomen, right? So we have different types of stomas, and they're in different areas of the body, and they're there for different reasons, okay? A stoma is just the inside structure coming to the outside. What they do is they mature it, so they fold it out and sew it to the skin. So you've got your large intestine, so then that would be a colostomy. Then you got your small intestine, that would be an ileostomy. It has frequent output, very liquid. So I always try to remember the IL, like a liquid. The colostomy is very formed, so that's going to be a formed stool coming out. And normally a colostomy is going to be on your left side, and an ileostomy is going to be on your right side, normally. And you can also have them transverse, there's different places that they can put them. They can be up high, they can be down low. You guys probably wouldn't be involved in the assignment of where one would go, but surgeon were to call you down because you know the structures, the biggest thing is to look at the patient's vision, where they're looking at their stomach, and so you want to put it where they can see. You know, so if it's a colostomy, you want to put it to where they can go, oh, it's right there. You don't want to put it below to where they're going like this, because now there's going to be a problem. And then also looking where their belt line is, where their pants sit, okay? They can also have the same stoma for urine. So your nephrology doctors will go in there sometimes, your urology doctors, and they'll reroute from the kidney to a bag. So those are little tiny itty bitty ones, and they can be anywhere, wherever they put that, and it's gonna be urine coming out. And so you know through looking at your labs and whatnot, ins and outs of patients, that the average patient should make anywhere from 30 to 100 when it comes to urine in an hour, right? So they're making this amount of urine. I'd say 30 is kind of bad and they're dehydrated, so they should be making more than that. Yes, so you gotta just kind of watch that if you've got a patient with that, because that bag's gonna fill up fast on you. So it's good to put a leg bag to it. It's another MacGyver thing. But you can put a leg bag to that appliance, even if it's an ileostomy. So that's a liquid stool coming out because it's from the small intestine. You can put a leg bag to that and just kind of attach a tubing, and it gives you another 500, capacity, so the person can still at least get down the hall with you before it has to be empty. So just different types. You've got your oval. This is just a very big mast type, and we've got necrotic tissue already peeling off of it. And then this is one that is just like a little rosebud. You can have lots of issues with them, just depending on the patient. Colostomies. And normally you're going to see a wound vac with it because they open them up to make it. Normally these are urgent. They got to open them up because they have a perforated, something's perforated within them, or they have a mass of some nature that needs to be moved, diverticulitis. There's a whole bunch of reasons these happen, but normally there's a wound vac in place. But standard stool from the colostomy isn't going to cause an issue, so just think about it this way. When you use the restroom, normally you don't have an issue. You go, you wipe, you're fine. But when you have diarrhea, that's a different story. It's the same thing. So a colostomy, their skin normally will be completely fine. It's complete waste, they can get rid of it. But when you have diarrhea or you have an ileostomy, it's a liquid stool. So you have stomach contents like acids that are within your stomach now on your skin, and your skin is not meant for that. So you're going to have skin irritation. Just kind of some of the things you're going to think about: barrier products, decreasing odor. They can have a regular diet. They need plenty of water, because they have no control now. So their sphincter is not in control of when that stool comes out. So they've got to stay hydrated, even more so than the people with the ileostomy, because they all need to stay hydrated. Sometimes there is blood when they clean this stoma. You can imagine, see this little bit of blood. When I touch that, if I look at my tissue, it's going to have a little blood on it. That's okay. If it's gushing, if it's pouring, we're going to have a problem. Pressure needs to be applied, and you need to call the doctor right away or give them to the ER. Ileostomy, they're normally smaller, and as you see, it's eroding the skin because it leaks a lot. It's just got a lot of fluid to it. It breaks down the barriers that you put in place, and it breaks down the fluid fast, really fast. It's stomach acid. So. I don't see a lot of them with a really foul odor, not like a colostomy. And the other thing is these people have no control of their farts, so they just go. They're in that bag, so I like to tell them, well, it is a controlled fart because they can release that at any time. So if someone's in the room that they don't want in their room, they just need to pop that open, and everybody will leave. So it takes all of these stomas to really become active because there's trauma. So that you'll see, if you're seeing it first after surgery, it's gonna be swollen, it's gonna have edema to it. Once it slows down and decreases, it'll have more of a stable look to it. It won't look like clear jelly on there. Lots of fluid with them too. You can see food pass right through it, you know. Somebody will give a patient medication and it'll pass right through, you see it, you're like, oh, well, there was their pain pill. It just went right through. So urostomies, like I said, this is for urine. These are a little more difficult to manage. They're smaller. We do have bags in place for them, but they've got tubes in place too. So normally the surgeon places it and monitors it, and they only ask you if absolutely needed. The surgeons here that do this type of procedure, they normally don't involve wound care. I don't know why. They don't like us, or they don't think we're competent. I don't. But they don't normally ask us. So there's a, on these appliances, there's a spigot. So it's like a spout. And then because it's just urine that comes out. So you don't per se need to have the standard fold and clip bag. Which there's a lot of appliances out there. An amazing amount of appliances out there that make you nauseous. They do have a cool feature in a lot of those bags, and it's for reflux, so it doesn't go back in. So they have this little cover in the pouch that stops the urine from going back.
What are those spots going into the kidney, so that you don't have kidney?
The drains. Got through it. You guys did it. It was a lot to look at, I know. But we can turn the light on and you guys can see this. So I'm just gonna put this canister, thank you. This canister slides, and when you look, it just has this nice little area on here to slide into place, and it clicks. Really simple. Now, some patients will have incisional, so let's say they've had a hip surgery. Now they're home and you're gonna be seeing them. You might see something like this on them. This has silver in it and it stays in place, so hard to see. But the has a silver lining, so it can stay in place on top of those sutures or the staples, whatever they have. It sucks down. The seal is actually right along the edge. It has nothing to do with this part. We have a different amount of sizes for these. The patient just takes this little device home with them. They're to go back to their surgeon in 14 days to remove the staples or the sutures, and when they do, they drop this little thing off and they recycle these. So this is kind of a nice little way of decreasing the amount of care that they need, so less hands-on and the person can go home. But it's normally just, this is just an incision, this is not an open wound, just an incision, so everything is closed. But if they have an incision, this is my little makeshift thing here. There are so many videos online, you can watch tons of stuff when it comes to wound vacs and how to place them. It's super cool, but they all take time, so I wasn't gonna bore you with watching this whole long thing, and then especially if some of you are never gonna do this. So if you are gonna have to do it, my recommendation is to watch a video from KCI. Sit down, watch one of their videos before you do the procedure. Super simple, very educational, okay? So I would have cleaned and prepped my wound, I would have skin prepped, I would have put my foam or whatever I need to have inside my wound, and now I'm gonna cover it with drape. Then you cut a little track, and then you're gonna put your track pad on it. Okay, so it's all ready to go. Then we have all these different options. So the standard wound vac is right here. Then we have a Veriflow, that's the Insil that I passed around that you guys were looking at those photos. Then we have the Prevena, that's what this is. So if the surgeon wants to keep them in-house for whatever reason, we can still do that incisional vac, just hook it to our big unit, so it's all manageable. And then the Apthera, and that's when the abdomen is open. And you'll know because that's a blue foam that they use, okay? And like I said, you don't mess with these people, they're having a blue foam, leave them alone. But an ICU nurse will slap your hand anyway, so you don't have to worry about remembering that. You're definitely not gonna see them in the outpatient setting. So this is just a standard, so I'm just gonna hit my standard button. There's a whole bunch of things that you could do and change and modify. I'm just gonna go with what the standard is, okay? So I'm just gonna tell it, okay, we already have it set up for that. So it's gonna try to suck down. You can help it by touching it, but you see it's starting to vacuum. And then it like putters. So I might have a little leak somewhere. I have to change this dressing out every once in a while because sometimes it just builds up with tape. But I'll leave that on for you guys to look. Most patients don't have a problem with it. They don't complain about it. There is a battery life to this, so if you want to take them out walking, you can. Just take the extension off. Every battery is a little different, as you know, so you could have anywhere from 3 hours to 6 hours to 12 hours. Who knows how long you keep it plugged in is going to determine that. Then they have home wound vacs. They're like half this size, and I don't have one to show you. I'm sorry. But they have little tiny canisters. Everything's itty bitty about them, and they normally wear them around their arm, and it's just a little tiny unit. It's at 125, no bells and whistles. It's just to suck down, get the drainage out, and it gets changed to outpatient, or someone comes to their house from home health to have that changed. Just the drape for that, this standard dressing here would have this green coloring on it. The type that was in that Ziploc bag, that's Instill, so it's meant for moisture. Now, you can use those for other things. You can, use that tape for other stuff. We also have, I just put stuff in baggies so you guys can easily see these are stuff that we would use to secure something down. Pretty simple. The products that you would use when it comes to your stomas, you're gonna wanna protect this skin with some sort of spray. So this is like the skin prep, but in a spray form. There's also powders that they have that they can put, that skin that was irritated. You can use this. So I'm just going to demo how it comes out in a stream. You can just shoot it out. So you can put that on the skin, you dust it off, just like that. And there's a fine layer already there on my skin. And you would come through with this stuff. And do that to them several times or once, depending on the rash from the stool hitting the system, right? Hitting the skin. So then that's called crusting. So that's something that you can do even around wounds. So if there's a constant drainage, I just put this protective layer on my skin for it to eat through that before it touches my skin. So you can do that. And almost all of the stoma appliances would have some sort of medical adhesive that you can use. And I've used this on wound vacs too. So, we've had to place vacs on groins, on buttocks, armpits, heads. I've placed them on heads multiple times. This stuff is a lifesaver after you shave all the area to get it to stick, because those are areas where we have different types of glands and different types of moistures. Okay? So you can intertwine your products. If it's okay for the skin, it's okay for all the skin. I told you about that. One of the things that we do have too is Vage. So this is a really good wound cleaner. It has a pretty strong smell to it. So when you guys come up, you can take a whiff of it. It reminds me of pool cleaner. But if I put this inside of a wound and I let it soak for a little bit, all the product tissue floats to the top. So that you just wipe it out and it can help you out a lot in cleaning up a wound. Do you guys have any questions? Anything you can think of it. No? Yes,
If you'd be one that you prefer to do wound care, are you at the hospital, are you going everywhere, are you in the?
so I'm just at the hospital, so I'm acute wound
Oh, I
care.
meant like in the hospital.
Oh, I go to every floor.
everywhere.
Yeah, so, we get assignments in the morning and then, just like the therapists do, we all have a board and we get assignments and then we head out. So right now we're trialing a little, something different because we're really trying to catch all the pressure injuries. So we're being assigned a floor. So like last week, I was medical floor and cardiology. So I was the nurse for that entire floor. So if there was wound care that was time for me to do, then I was doing the wound care. So we're each just trying that out, because before we go to just all over. We just took the next assignment. And so now we're trying to just stay on that floor, get to know the nurses, and go that way. But at any time, we could be called to the OR. Or called down to the emergency room to troubleshoot something, to figure something out. So, yeah, kind of go everywhere. We do have an outpatient here, there's an outpatient wound care, but then those are chronic wounds, so that's a little different than acute. So the stuff that I showed you today, those are acute wounds. They need treatment now, someone needs to get on it, fix it, or at least have some sort of plan in place. Once that plan's in place, then they would go to outpatient, or home health would come and do it. And at some home health places, they'll have the therapist do the wound care. I mean, it's just their job. So they'll not only go out and move the person around and do all the exercises with them, they also will do their wound care. Which makes sense too, if you think about it. You know how that leg is gonna move. So you know how to put that dressing on to where it can still flex and it still can use it. Nurses don't always think that way, you know, they're not thinking of how the body's moving. It's more of a system, soft organ thought process. And you guys are thinking more of the larger structure process. So a lot of the nurses will put a dressing on and I get a call in an hour that it's popped off. Well, how'd you put it on? You know, did you do it in a triangle? Did you do it to where you're watching how that leg moves, or do you know what I mean? So sometimes it is very beneficial to have the therapist do the dressings just because their thought process is completely different than the nurses. Like I said, so much drive me crazy. Like seriously, I just want to tell you what happened. So this is Inner-Dry. We have this at the hospital. It has silver in it, and this is your friend. So skin folds, moisture, you know, there's a lot of people that have sweating issues and whatnot, and you're moving them around and there's odors. This, you put this up under the skin fold, and it wicks the moisture away. So you gotta have some of it exposed for it to do that. Don't hide it up under there. Keep a piece of it out. But the silver will kill the bacteria, so it kills the odor. Because the odor is coming from the bacteria, eating in its waste. And so then that's what you're smelling. So this kills that. So this can decrease the fungus and whatnot that's up under skin. And that woman I was telling you where I had to be thinking about addressing her buttocks, I stuck this in between her butt crack. So as she was sweating in those horrible hospital beds, everything wasn't sticking together. She stayed dry. So normally if I feel that they need it, I'll send the whole box home with them. Now it can stay in place for 5 days. Some people say 7, but I say 5. And you only change it out if it looks soiled. So it starts looking nasty, of course, get a new piece, but otherwise you can still use it. I don't think they have this at Walgreens, but they do have Meta-Honey at Walgreens, which I have up here somewhere. There's a bunch of different types of honeys that you can use on wounds. I love them. They kill bacteria, they kill odor. They degrade slowly, but it does work. It's very natural. So depending on who you're working with, silver and honey are natural products, and lots of people are totally cool with you using them. You tell them you're going to put some sort of chemical on them, and they're like, yeah, no. So keeping those things in mind too. So if you guys want to come up and look at products, you can. If you have other questions, I'll do my best to answer them. months.